colleagues, I would like to speak these 10 minutes about the use and misuse of topical corticosteroids in psoriasis. The current use of topical corticosteroids. We have to realize that most patients with psoriasis have as first treatment a topical corticosteroid. So it's used very much by a lot of patients all over the world. The current use is a mainstay in topical treatment of psoriasis. It can be done as monotherapy or in combination with calcipotriol, the vitamin D analog. A characteristic is that it is effective within 3 weeks, a very fast reach of efficacy. But there is tachyphylaxis, some form of habituation. The good news is that there are so many vehicles that can be used: lotions, creams, gels, foams, ointments. And also access to care is worldwide. In nearly all countries in the world, there is availability of topical corticosteroid preparations. A few words about the efficacy and the safety. This is the combination of betamethasone dipropionate and calcipotriol. Once daily applied, 56% of the patients reach the PASI 75. And when you apply this combination therapy twice daily, then about 68, 77, 76% of the patients reach the PASI 75. So in general, once daily applications are advised for the combination. When we give the monotherapy of betamethasone dipropionate, you see that the difference between once and twice daily application is not that huge. And in general, we advise only to apply a topical corticosteroid once daily. 45 till 55% of the patients reach the PASI 75. When we look at these figures, we cannot compare that with the systemic therapy results for reason that the populations are different. That is, patients who are candidate for topical therapy in general can be treated much more easily than patients who are candidate for systemic therapies. But these are the figures in this population of patients, which means that actually they provide the solution to a lot of patients. But there are side effects. We cannot ignore them, the side effects. There are local side effects: atrophy of the skin, dermatitis perioralis. There are systemic side effects: suppression of the HPA axis, Cushing syndrome. In children, there can be growth retardation. Then with respect to the eyes, glaucoma, loss of vision. Then avascular necrosis of femoral head and severe disseminated cytomegalovirus virus infections. And during my career, I have seen in patients several of these side effects. I quite often have seen patients with atrophy of the skin and dermatitis perioralis. And also quite often, when you measure it, the HPA axis suppression. And occasionally I saw Cushing syndromes. And the other side effects, the more severe side effects, it was very seldom I have seen them. They may occur, but they are not very frequent side effects, the seldom ones. There has been done, however, only one long-term study on the efficacy and safety of topical corticosteroids, and that's amazing. Amazing for a treatment which is used so frequently that our evidence regarding long-term efficacy and safety is so limited. It was a comparative study with 2 ways of treatment of the combination calcipotriol betamethasone dipropionate. And actually, what was seen during this treatment was that in the red line, the combination of calcipotriol and the corticosteroids given here continuously. In the blue line, it was the intermittent use, but let's concentrate on the continuous use of beta-metazole dipropionate over time. You see that during time, there is a slight decrease in efficacy. So percent of patients reaching clear or almost clear skin, 70% to start with, and going then to about 60%. And in some patients, we indeed have observed atrophy of the skin. The number was limited, but don't forget, beta-metazole dipropionate is a strong corticosteroid and not an ultra-potent corticosteroid such as clobetasol 7-dipropionate. For the corticosteroids that are designated as ultra-potent, we simply don't have long-term efficacy safety data. And nevertheless, these treatments are used long-term. Topical corticosteroids in plaque psoriasis is a systemic review of the risk of adrenal axis suppression and the skin. Altogether, in this review, there were 1,269 references found, and a total of 22 randomized trials were selected. And in this study, although short-term biologic effects of topical steroids on HPA axis were observed, in clinical studies, they were not associated with clinical signs. That means when we look in the literature, we can see suppression of the HPA axis. Actually, I've seen that also a lot when you look for that. But when you look at the clinical consequences of that, these seem to be limited. Limitations of topical corticosteroids at high impact sites. You see here some high impact sites like scalp and face, like submammary, like palms and soles, and like the face. Well, to start with this one, you see here true facial psoriasis, and this patient was not treated with a systemic corticosteroid for simply that we were afraid of the induction of dermatitis perioralis, and the patient was treated with a calcineurin inhibitor. In such a situation, you do not want to go for a corticosteroid. Also, in the submammary region, you have to be afraid of striae development. And the palms and soles, the skin is very thick and it is very difficult to get penetration of corticosteroids. And the same holds true for scalp psoriasis. Striae. Striae can already occur with potent and ultra-potent corticosteroids within a few weeks of application, and they never will improve. Patient has lifelong these features, these striae, which can be quite distressing for the patient. Dermatitis perioralis as a side effect of the use of corticosteroids in the face. The maximum continuous dosing and timing for Difobet, the combination with calcipotriol, is 4 weeks continuous use, and after that only intermittent use. The very strong one, clobetasol 70-propionate, it's 2 till 4 weeks, depending on the local guidelines of the continuous systemic therapy. Beta-metazole monotherapy, 4 weeks only continuous therapy. And longer than 4 weeks, you have to give an intermittent treatment. As IPC, we have defined recently the topical failure. And the definition of the topical failure is established. We found the following consensus in the International Psoriasis Council. That is, what is actually failure to topicals is inability to achieve clear, nearly clear skin, BSA smaller than 1, PGA-001 after 2 consecutive 4-week topical therapy courses per guidelines. Strong consideration should be given when a patient self-reports moderate severe psoriasis despite the provider's mild assessment and experiences significant physical, psychological, social impact. So, at the moment, still a lot of patients continue with topical corticosteroids, although they are a failure. They have not enough result, not enough improvement. And it is important to switch them to another treatment. Don't use the topical corticosteroids when they have not a good effect. For when there's one thing is not to have a good effect, and the other thing is also the risk of actually getting the side effects. But when you have a good effect, actually, it can be that you continue. And here also the IPC gives guidance. If effective and well tolerated, topical treatments must be used for can be used and must be used for prolonged periods of time. However, potent corticosteroids should not be used continuously for more than 4 weeks. And super potent ones should be limited up to 2 till 4 weeks. So here the IPC says those patients who respond well to topical corticosteroids limit the continuous use to only a few weeks. And I think this is very important to realize this and to avoid the side effects. These days, we speak a lot on psoriasis as an immunometabolic disease. And on this slide, you see how interwoven actually the immunology with the production of IL-17, IL-22, angiogenesis, and on the other hand, also the impact on lipid profiles, lipid metabolism in the liver, endothelial damage, plaque growth of the adipose tissue, insulin resistance. And actually, corticosteroids enhance this process, enhance this comorbidity. So it is important to be reluctant for an exposure of too many people for too long time with corticosteroids. And also topical corticosteroids have systemic availability. So it is important to use the topical corticosteroid in a restrictive way. They are not absolutely safe, especially not in psoriasis. In psoriasis, they have an impact on the metabolic aspects. Corticosteroids enhance hyperglycemia and diabetes. Via systemic absorption may cause Cushing syndrome, and I've seen it in patients. Weight gain and obesity, metabolic syndrome risks are well known to you, and important is that already in children with psoriasis you can see it. Do we really want topical steroids to be the mainstay in patients with mild psoriasis, where we define psoriasis as an immunometabolic disease? It's important that we think for the future about other strategies. Safe use of topical corticosteroids. Have a look at topical failure definition of IPC and adhere to the IPC definition. Potent corticosteroids not be used continuously or for more than 4 weeks. Super potent ones should be limited to 2 till 4 weeks for the continuous use. And later on, after that, you can use corticosteroids topically for a few days per week as intermittent therapy. Note the local side effects, inconvenience, and restricted bioavailability of topical corticosteroids at high impact sites. You may induce here striae, you may induce dermatitis perioralis, and be aware that psoriasis is an immunometabolic disease which requires modest use of topical corticosteroids. What to do? In such a situation, you can go for a systemic therapy. In earlier days, the topical therapy remained the mainstay, but actually the transition to systemic therapies and more safe systemic therapies have become available, which are well tolerated by the patients. And also in the topical therapies, there are innovations. Tapinarof, which interferes in a way similar to coal tar, but without the side effects of coal tar, and reduction of relevant inflammatory cytokines, increase in antioxidant response, and restoration in the barrier function. And there is roflumilast with a phosphodiesterase E4 inhibitor. And also roflumilast has a robust efficacy, PASI 75 reached in 31% of the patients. So with respect to the topical corticosteroids, I realize topical corticosteroids will remain an important therapy in patients with mild psoriasis, but adhere to the IPC advice. Over 4 weeks, go to intermittent therapy, and also define strictly when a patient is a failure to treatments. Thank you very much.